Assalamu alaikum and welcome to the program Ramadan for Better Health. Today we're going to be talking about cancers, particularly that our sisters suffer in their reproductive organs. We're joined by a specialist in this area. This is Dr. Ahmed Sikuture. He has worked a number of decades in the United Kingdom at 2 universities. There's the Christie Hospital, which happens to be the largest cancer institute in all of Europe, as well as he was a director for gynecology at the University of Southampton. He's currently working in Egypt as a professor at the University of Alexandria. Assalamu alaikum to you, Dr. Ahmed.
South Manchester, by the way.
South Manchester.
Yes, that's right.
So thank you, and sorry for that.
That's okay.
So we're talking about the cancers that the sisters suffering in their reproductive organs. This is your area of specialty.
That's right, yes.
Let's see, how can we start this conversation? First, let's answer the question, where and which part of the reproductive system of the women do the cancers most often appear?
Right. The reproductive system of the woman consists of the ovaries,
yes,
then the attached fallopian tubes from the uterus, the womb, which is the uterus, neck of the womb, and the vagina, and the external genital organs. And cancer can occur in any of these organs. The commonest, sites for cancer are cancer of the lining of the womb and cancer of the ovary. And then, obviously, this is in the, western parts of, Europe and the States. However, in certain parts of the world, like in Southeast Asia and Sub-Saharan Africa, for example, cancer of the neck of the womb is the commonest cancer. I'm excluding breast cancer here. I'm talking about cancers of the genital tract in the pelvis.
Ahmed, sorry to interrupt. Just to clarify, when you say neck of the womb, you mean the uppermost portion or the lowermost?
The lowermost portion. That what we call cervix.
Okay.
Yeah, the cervical cancer. Certain parts of the world have prevalence of different cancers, as I mentioned to you. Yeah.
Okay, so you've helped us understand that the cancers, the location of the cancers in the womb varies a little bit from country to country.
That's right.
What about the numbers of women in globally, worldwide? Right. What percentages of women have this unfortunate hardship of enduring cancer?
Right. I mean, it varies from cancer to cancer, and whether the country will have a program for screening or early detection or prevention of that cancer. But in general, cancers of the female reproductive organs constitute about 10 to 13% of the cancers that affect women.
Okay.
And again, I'm talking about the cancers of the ovary, womb, neck of the womb, vagina, and external genitalia. I'm excluding the breast cancer from this because the incidence and prevalence of breast cancer is much higher.
So again, between 10 and 13% of women who have cancer.
No, yeah, that's cancer of the arising in the genital tract.
Ah, okay. So that's a little
substantial minority.
Yeah.
Yes. Yeah.
All right. So let's talk about some of the causes. You mentioned, I'm very interested in what you said, that different parts of the globe have different prevalence in terms of the location of the cancer.
That's right.
Does this also mean that the causes also vary?
That's right. And you can look at cancer in general as a disease, and there are causes to cancer in general, and there are things that we could do to prevent or reduce the risk of cancer in general. So cancer in general could be caused by problems in the genes. That's hereditary cancer, familial.
Is this the primary cause?
Not necessarily.
Not necessarily.
Not necessarily.
Okay.
Yeah.
Mm.
There are cancers that we know can be caused by certain agents. Like, for example, the best example, we know that smoking causes lung cancer, for example. So you can say, well, okay, if you stop smoking, you reduce the risk of having lung cancer. We know certain cancers in the gynecological organs can be caused by viruses, like human papilloma virus. There are types of this virus, but the major two categories are the low risk category and high risk category. The high risk category, if the infection with high risk category persists in the neck of the womb, that's after many years, it firstly produces changes that are pre-cancer, not cancer, but if left for some years, it can turn to cancer. So we know that this virus, if it persists and infects the neck of the womb, can cause cancer. We know that if you give a lady, for example, estrogen only for a prolonged period of time, that can cause changes of the lining of the womb, and these changes can be pre-cancer and then after some time can cause cancer. And in general, pollutants can cause cancer, environmental, pollution. That's not insignificant cause of cancer. So, reducing the risks of exposure to pollutants, leading a healthy life, not smoking, making sure that you're not subjected to infections, particularly infections that are known to cause cancer, can all reduce the risk of cancer.
Okay. And let's talk a little bit about cancer screening. What are some of the signs that women should expect if they have a cancer that hopefully the best case scenario, I imagine, is that it's detected before it becomes advanced?
That's right.
But let's say the sister doesn't have a routine practice of going for screenings. What kinds of symptoms would start to manifest?
That's a good question. And in fact, we need to tackle or shift the management or the plans from treating cancer at its advanced stage or medium stages to really prevention, if we can do.
Right.
Early detection, screening, that's the best case scenario if we can't prevent it. And that improves quality of life of the lady.
Absolutely.
And also saves money for the government. And that money can be reallocated to improve health in other aspects and different aspects. In terms of, let's talk about screening, but I'll also talk about prevention of gynecological cancer. What state of that is on the scenes at the moment? In terms of screening of gynecological cancers, the best model that has so far been practiced is the screening for cancer of the neck of the womb. We call it cervical cancer or cervical cancer. And obviously the United Kingdom is one of the countries that is pioneering in a very effective screening program. And the screening for cervical cancer is very good because you have a precancerous phase that you can look for and detect and treat before it becomes cancer. And the screening modalities for cervical cancer varies depending on the country's resources, the prevalence of the disease and the incidence of the disease. Disease with a high enough incidence and prevalence can justify, in terms of the health economics part of it, to have a national screening for the high-risk population. So the high-risk population for cervical cancer are those who are, sexually active. Married women and sexually active women are exposed to that particular virus.
That is a question I wanted to ask you. The viruses in the reproductive organs of women, are they introduced through sexual activity, or do they come about through other means?
Well, I mean, the major mean is sexual activity, but they can also be introduced via other means. Uh, and they can stay dormant for a long period of time. So not necessarily that a recent infection means that there is a recent exposure. Exposure could be old, and then the infection came recent. And although this is something that we are now thinking about in terms of the prevention, because if we know that's a virus, we can design a vaccine for that, and it's been designed, it's been implemented, and there is a cervical cancer prevention program that is being implemented in the United Kingdom, for example, where young girls get routinely vaccinated before their sexual activity and all that. So there is a screening program that is effective for cervical cancer. The lady should start it once she is sexually active, and it is done at the gynecology clinic usually, or a designated screening clinic, by taking a smear, cellular sample from the neck of the womb, and either smear it on a slide or put it in a special liquid, and look at it under the microscope to check for cells, for abnormal cells. And also look at the neck of the womb with a magnifying lens called colposcope, for example, and there are variants of that, portable colposcopes. And detecting the abnormal areas, taking a little tiny piece of it called biopsy, looking at it again under the microscope, and if it proves to have some pre-cancer changes, then you can easily treat it in 10 minutes.
Okay, another question related to the viruses that may or may not be there. Are you saying that there's a link, a connection to any type of sexually transmitted viruses and the development of cancer? Is there a connection between?
True.
Okay.
Yes.
All right.
So there is a connection, and then the advice of how to prevent that and how to avoid that becomes very important.
Yeah.
But let me completely for you one last thing about the screening, because
can you hold it? We're at our break point.
Okay, then. No, I can perfectly hold it.
All right, great.
Okay.
We will continue with Dr. Ahmed after a short break and continue the program. Assalamu alaikum and welcome back to Ramadan for Better Health. We're here with a consultant gynecologist, Dr. Ahmed, and we were talking, Dr. Ahmed, before the break about screening. Can you please continue with...
Thank you, yes. We were talking about the screening for cervical cancer.
Yes.
This is a very important issue actually in Southeast Asia and in Sub-Saharan Africa. And we were mentioning that the high incidence or prevalence of certain disease justifies putting money into screening for it to treat the precancerous or the early phase of it. And we were talking about the screening that can be done by taking a cellular sample, just smearing from the neck of the womb and looking at it with a magnifying lens, for example, and taking little tiny piece like a rice grain size biopsy from the neck of the womb and looking at it under the microscope. If there are any changes, you can treat it effectively in 10 minutes, and the lady goes home, and that's fine. Yeah. Now, in certain parts, setting up a clinic could be a little bit costly, doing the smears and having the designated lab and staff and personnel to process the smear, stain it and look at it, or looking with a magnifying lens, at the particularly the traditional colposcope, which is really a sizable equipment, very heavy, very expensive. So in Sub-Saharan Africa, Southeast Asia, you can do screening with acetic acid, dilute acetic acid in the normal gynecology clinic. And that's actually a method that is recommended for low resource countries by the WHO.
What's the name of this acid again?
Dilute acetic acid.
Acetic acid.
Yes, dilute acetic acid.
So it can be any acidic.
Yes, yes, from the store. You dilute about 3 to 5% dilute. And you can apply it to the, obviously you have to discuss with the lady what you're going to do and take some, her consent for that.
Right.
Examine the cervix as per the normal gynecology examination, and then apply some fluid of that dilute acetic acid on the neck of the womb. Look with your naked eye on it. And the changes will appear with different, color, whitish color. And then you can gauge whether this is really significant change or not significant. And if it is a significant change, you can elect whether to treat, if you are equipped to treat straight away, or you elect to and have the enough expertise to gauge it, or take a little tiny biopsy, check it, and treat if there are abnormalities confirmed on the biopsy. Now there is, portable colposcope coming up, and that we hope that this will allow, that's less expensive, less bulky, very small equipment that can be carried into remote areas and clinics and all that.
And less expensive, I imagine.
Less expensive, that's right. And the screening duration varies, not less than 1 year in any case, not before sexual activity in any case. And for example, in the States they screen every year for ladies from, I think, in their early 20s. In the United Kingdom we screen from 25 years up to 64 years, every 3 years until she is 49, and after that every 5 years, once every 5 years. So in any case, not less than a yearly screen if it is negative, normal, and not before sexual activity. Now, the new thing about this is that now there is the vaccine to prevent that type of cancer altogether. Would there be still a place for screening if you're giving vaccine to prevent it from in the first place? Would you still be screening? So we still need the screening, I think, for the next decade at least, until we confirm the protective effect of the vaccine. Once we are in a state and saying, okay, that cancer is becoming very low incidence and very low prevalence, and we cannot justify putting money to screening on that, we cannot screen for it, we do not need to screen for it, then we stop screening and continue with the prevention with the vaccine.
Now, Dr. Ahmed, I promised you that I was going to try and connect this with the topic, the theme of our program, Ramadan.
Yes.
In Egypt, I don't know about throughout the Muslim world, there are a great many couples who get married at the end of Ramadan.
Right.
So would you recommend, prior to actually being married, anything different before and immediately after marriage in terms of screening, in terms of the screenings?
Right. That's a good question. In terms of the screening, you screen for the general well-being in terms of both couples. You can screen for their fertility status, and you can screen for hereditary conditions, particularly if they are relatives. So, for example, the lady can, if she's having regular periods, and she wants to make sure that the function of the ovaries and the reserve in her ovaries are good, she can elect to have a blood test in the second or third day in the morning of her period to check on her hormones and all that. She can elect to have an ultrasound scan on the pelvis to make sure that the womb looks not normal, the ovaries, they look normal, nice, no cysts and no swellings and no tumors or anything like that. It's very, very rare to have abnormalities in young ladies approaching marriage and all this. She doesn't need to do any more screening than that. Screening for cervical cancer is invasive, because invasive in the way that there's something introduced down below to look at which in Islamic countries might not be appropriate if she's not married yet.
Did I understand you to say that general advice
Yes.
is that before getting married, just do, if you haven't already, the sisters should take a look at just a general preventative screening.
That's right.
Okay.
Yes, yes.
And if many couples are getting married after Ramadan, then Ramadan could effectively become a floating
Yes.
gynecological health month.
Absolutely, that's right, that's right.
Okay, so let's talk a little bit about family history. If the sister knows that her mother, grandmother, aunts, maybe sisters have gynecological cancers, should that alert her to anything different than normal?
Yes, that's a very good question, because we know that we've mentioned in the first half of this talk that certain cancers can be caused by some abnormalities in the genes.
Mm-hmm.
These abnormalities can be traced in the family.
Mm-hmm.
Now, one of the famous, or one of the most common cancer that can be caused by the genes in women in the reproductive organs is the familial breast and ovarian cancer syndrome, or familial breast and ovarian cancer condition. And that's caused by some abnormalities in two genes called BRCA1, BRCA1, and BRCA2, BRCA1 and BRCA2 genes.
Mm-hmm. Mm-hmm.
Now, so if we take the pattern of family history of that abnormality, we find that it's first degree relatives, or maybe 2-3 second degree relatives having breast cancer
Mm-hmm.
or ovarian cancer, particularly at young age, below the age of 50, for example.
Mm-hmm.
That should alert the family, the patient herself. Then the next step is to see a specialist in cancer genetics. Obviously, see if the family, if the affected person in the family with that cancer, they will get treated
Mm-hmm.
by their cancer surgeon, which is a gynecological oncology if it is cancer of the ovary, or surgical oncologist, if it is cancer of the breast, for example.
Mm-hmm.
Some countries, the one person can treat both. And that affected person can actually get tested for abnormalities in that gene.
So you're saying that it's there are methods, there are clinical methods to determine whether or not the sister has the gene that will cause her to develop
Yes.
Cancer in both areas, the breast as well as in the ovaries.
Yes, that's
Wow.
right. So that's in terms of the affected person. We can look at the abnormalities in all that gene. If we find an abnormality positive in this part of the gene, then we can test members of the family, the female members, about this abnormality.
If this is the case, if it's in the genes, then it can be done at birth. I mean, as early as she's very early in life. Is that correct?
In theory, yes, it can. But what benefit you're going to get from that? The risk starts to develop in the latter part of the 30s. Yeah.
So you mean to say that if the sister has the gene, there's no guarantee that it's not automatic that she's gonna develop the cancer?
There is a high risk.
Okay.
So let us talk about the risk of if a person has got a positive abnormality in the gene, in that particular gene, the BRCA1 gene, for example, the risk for having the lifetime risk for having breast cancer in that affected person can be up to 85%. So that's a significant risk.
Yeah.
The risk of having ovarian cancer in that particular person is about 47%. Okay, so that's another significant risk. And there are measures that we can do to reduce that risk substantially. Okay, but I'm talking about the predictive screening now, the screening the family members to check on that particular abnormality to identify their risks of having the gene and the cancer if the gene is positive. But this is in a scenario where the affected person with the cancer in the family has been tested. But what about a woman that is talking to her cousin in Australia, for example, and she's in Egypt? And the cousin said, oh, I've just been diagnosed with breast cancer, and she's only in her 40s. And she mentions to her, well, my other cousin who's in the state, our other cousin in the state, has been diagnosed with, sadly, with ovarian cancer, for example. There is no access for them to be tested and the test materials to come to Egypt. So that person in Egypt is eligible to get tested for mutations or abnormalities in that gene to predict, but they will test the whole sequence of the gene. The whole areas in the gene will be tested to identify if there are any abnormalities.
Dr. Ahmed, we have come to the end of the program. We've got just 1 minute. We want to ask one final question about fertility, the connection between ovarian cancer and fertility. Can you talk about that in about 1 minute?
Okay, then, thank you. Well, we know that ovarian cancer is a disease of the older women, but about 5 to 10% of it can occur in women that's still having periods. There is a condition that is not frankly invasive cancer called borderline tumors, and that tends to occur 10 to 15 years younger or earlier than the ovarian cancer patients. So in summary, if the tumor is affecting only one ovary, and that can be predicted by appropriate imaging, appropriate imaging modality, and during the surgery that's not spread in the abdomen and inside the tummy, then a comprehensive, appropriate surgery that spares the womb and the other unaffected ovary is legitimate and can be done, and taking all the appropriate stuff that you need to take out during the surgery, like the piece of fat hanging from the stomach, some lymph glands in the abdomen, and all this, and biopsies and all that. And then she can be allowed to follow up strictly and regularly, being allowed to get married, to have babies.
Yes.
After having her family, completing her family, she can come back and we can remove the womb and the other ovary.
Wow. So it's very possible, even with gynecological cancers in the ovaries, that she can still, but if it takes early. If it's early, there's some conditions. All right, so we have to end here now. Dr. Ahmed Sekou Touré, he is currently a professor of gynecology at the University of Alexandria. He's also worked in the United Kingdom at 2 prestigious institutions there. We appreciate him being with us. Assalamu alaikum to you, doctor.
Assalamu alaikum.
And assalamu alaikum to you, dear viewers, brothers and sisters. Thank you for tuning into the program. We'll be back with more. Assalamu alaikum wa rahmatullahi wa barakatuh.